This is Health Matters, a program by the Ministry of Health. And I'm Nazim Hussain. Glad that you could be with us on today's program. We've got Dr. Navendranath Rambaran. He is the Director of Medical and Professional Service attached to the Georgetown Public Hospital Corporation. And with us also, we've got Dr. Smola Swan, Intensive Care Unit Specialist at the Georgetown Public Hospital. And we were talking about the Guyana Transplant and Tissue Agency, the Human Organ and Tissue Transplant Agency, of which Dr. Navendranath Rambaran is a member of that agency, and Dr. Swan has been recently appointed as transplant coordinator there at the GPHC. Doctors, welcome to the program.
Thank you, Nathan.
Dr. Rambaran, I'll start with you. Just for our viewers who might have missed a program about a few months ago when the agency had first started, tell us a bit about this agency.
Okay, so thank you, Nathan, again. The Human Organ Tissue Transplant Agency is one that was created out of the Act, the Human Organ Tissue Transplant Act, which is the law that governs transplants of organs and tissues within Guyana. It is a very modern actor law that was put together by a very dynamic team of local and overseas specialists working for several months on end to ensure that Guyana has one of the most modern acts dealing with transplant, knowing the kind of nuances and fallouts you can have for such activities. So I think overall we have a very good law that has now given us the guidelines under which we can operate and do transplants. So out of that act, it mandates that the agency, the Human Organ Tissue Transplant Agency, is formed and operates as one of the oversight committees dealing with all of the institutions that do transplants. So the agency is headed by a chairperson. That person is actually Dr. Shanti Singh, and there are several members who are appointed from the various hospitals and stakeholders agency. And I'm one of those stakeholder agency reps. So on the HOTA, that is the agency, and I represent the GPHC's interest. And Dr. Swan is the designated officer, which by the act or the law actually ensures that there's someone on the ground to oversee the processes of the transplants. So she, as a designated officer, works with the transplant team and the ICU team and ensure there's a smooth process from identification of donors all the way to the transplant. There are several things happening with regards to the development of the agencies and the regulations that guide it, but these all in the end aim to ensure that we have a very formal and a very well, not elaborate, but more so a well understood process that all can actually see transparently in how these processes are done.
Dr. Swan, congratulations, you've been recently appointed transplant coordinator. Tell us a bit about that and your role.
Thank you. Yes, so as the transplant coordinator, my role is to, as Dr. Rambaran said, to oversee the process of the day-to-day process. So my job will be to identify the individuals who can become donors, all right, and we have to follow through. There is an immense process relating and rigorous process related to transplant and organ donation. So, I will be tasked with ensuring that happens on each level. So, for example, we identify who are likely donors, then we do follow-up tests, we speak with the family, which is so important. One of the most important steps, approaching the family, getting people to understand what is it we're doing. And again liaise with the agency. So once that happens at GPHC, we identify possible donors. We then have to let the agency know what is happening, and then the agency will get back to me to say, okay, we have identified a possible recipient. Let's go ahead with the process. So then we continue at the level of GPHC, setting up all the services. Again, this is a multidisciplinary service, meaning that there are many different services, many different professionals involved. So it's not just one or two persons. So we have nurses, other doctors, theater staff, and so on. So my job will be to put all of these people, get everybody working together on the same level.
Right. We'll take a break, and when we come back, we'll have more for you on Health Matters. Don't go away.
The mosquitoes responsible for spreading dengue are most active during daylight hours and can breed in small amounts of still water. Here are some simple tips to safeguard yourself and your community from dengue. At home, school, or work, cover water collection points with a fine mesh or lid and regularly clean areas that can collect water easily, like plant pots, flower vases, discarded plastic containers, and pet water bowls. Ensure that your gutters and drainage areas are clear. Keep doors and windows closed or install insect screens to prevent mosquitoes from entering. Use mosquito nets, repellents, and vaporizers to keep mosquitoes away. And wear long-sleeved shirts and pants to protect your skin. Don't wait, act now. Together we can keep our surroundings clean and beat dengue. A message from the Ministry of Health.
Welcome back to our program. We're talking to Dr. Navendra Nath-Rambaran and Dr. Smola Swan, and we're talking about the Human Organ Tissue and Transplant Agency and their work. So, doctors, you're from the Georgetown Public Hospital. Is it that the only hospital that now can do the transplant, and then how did that all come about?
Well, yes and no. So whether or not we're the only hospital can do transplant. There are many hospitals, including GPHC, that have done transplant and will continue to do transplant. But with the advent of the agency that has the oversight over transplantation, the agency is now going through a process of regularizing and certifying these institutions to be transplant centers. And GPHC has been the first that it is done in this process, after having undergone a self-study and reporting, and then have an inspectorate do a thorough inspection of the SOPs, the protocols, the infrastructure, the human and material resources that are available. We have been certified as being competent to offer transplant services. And the big shift here is really the paradigm movement from not just doing live donor transplant, but moving towards deceased donor transplant, or otherwise referred to as cadaveric transplant, where we use the organs for those persons who would have wanted their organs to be used and their families' consent, where these persons who are deemed to be brain dead on a ventilator, we go through the process of identifying if they could be potential donors, and then we follow the process where we see if they're suitable donors and we approach the family. This is usually done by the transplant coordinator. And once the family are in agreement, then the donation process happens and there's an eventual transplant to give hope and life to someone who needs it.
Dr. Swan, is there going to be a special unit in the GPHC where, persons who have had successful transplant be taken care of? We know about the intensive care department, but is there going to be a special place or where persons who have successfully done a transplant be looked at?
Yeah, so we're definitely looking at that. And again, it is such a delicate process. These these recipients, as we know them, they are inherently sick. They're already sick before they have end-stage renal disease, so they are prone to things like infections. They can get infections easily. So yes, they are placed in a separate location to aid and facilitate a smooth recovery. Right.
We actually have a transplant suite. It's a smaller suite. At the GPHC, it's could accommodate, as far as I recall, at least 4 patients. And persons who currently benefit from live donor transplantation, they're actually cared for in that unit. As we expand and roll out deceased donor, we expect that there will be a greater number of transplants being done, and we anticipate that the space for the care of these patients will have to expand.
Dr. Raman, you mentioned it, and I want you to walk us through the whole issue of the deceased transplant. You did mention it quite briefly, but when our common man in the street would have heard the word deceased, it means the person's already in a morgue and they're already dead. And wonder, well, how can you, harvest, to use that word, an organ or tissue from that person?
Well, it's first to understand it's a technical term.
Correct.
And in no way there is no movement towards a morgue to use organs from persons who are in the morgue. These persons are considered deceased, or they have died for specific technical reasons, and in this case it is usually brain death, where the brain has died. And all of medical sciences has taught us that when someone is brain dead, they are clinically dead. So that is one of the transition our medical fraternity has to make, or will be making, just like many parts of the world where persons are deemed and certified to be dead once they're brain dead, because there's no return from that condition. And that's the paradigm or the basis on which the deceased donor is actually taken. So these are again persons who are deceased by way of brain death, but they're on a ventilator and they're kept supported by a ventilator that breathes for them. If that ventilator were to be turned off, they would cease to breathe almost immediately. So these are the classes of patients that we would approach the family, and especially if the person has had some expression in the past that they would be happy to be a donor should anything happen to them and be able to contribute to the well-being of someone else, then usually it is something that the family would consider. As a matter of fact, it's considered a very humane thing that even in death, when it's unexpected, that person could contribute to someone's well-being.
But in Guyana, how do you foresee, and if it has happened before, this, from your experience, both doctors, someone is lying there and they've been declared and brain dead, but they have not really, there's nothing written that they will have consented. The family can do that. What's that process? How does that go through? And, would there be an elaborate, and you did say time will be taken, you'll have to examine the person's entire medical record to ensure that everything, their bloods, their tissues, their organs, is suitable for a transfer. How does that process work?
So I'll ask Dr. Swan to actually outline. That's a very specific process.
Right. Yeah. That's got to be a textbook format.
Okay, yes, exactly. So first of all,
that's the case. The person's there on ventilator.
Right.
What happens? And you need somebody urgently who needs a kidney. What's the process?
Right. So let me just clarify before I answer your question that these brain dead persons, right, they are likely to be persons who have been severely injured in an accident. So, with brain injury, we would have admitted them. They come to the emergency department. They were intubated. They were placed on a ventilator, meaning that they couldn't breathe fully on their own. So they were initially placed on a ventilator. At that time, sometimes you do not know if they were brain dead, if anything can be done to help them. But that is the initial step. That's like an initial life-saving step, or at least what you try to do to help them. You intubate them and you put them on a ventilator. Then subsequent tests are done. Maybe they have a CT scan or an MRI, and then you get a clearer picture of what's happening. Okay, the extent of the damage then that has occurred. After that, they would have, let's say they go to the ICU on a ventilator, and we would treat them as any other person. We do not withhold any treatment or so they get a full medical care and attention that is deemed necessary in their case. And afterward, if we see that there is no response, there is no surgery didn't help, or they didn't respond to a certain treatment, and you look at them, you evaluate them on a daily, sometimes hourly basis to determine what their functions are. And after a while, the doctors, the intensivists and the neurosurgeons and the neurologists, we look at these patients and we do certain physical examinations. And when the point reaches when there's no response, there is absolutely no response to whatever whatever stimulus you perform, then we can tell with certain with certain surety that there is no function, there's no return. And then after that, in order to certify brain death, so more at least 2 specialists have to be present, an ICU doctor along with a neurosurgeon or a neurologist. They have to be present. These tests have to be done together with, it could be nurses, but at least 2 doctors. And they have to document all the findings, and everything has to be negative pretty much. So whatever they do, there is no response. And after that, then there is a final test that is to be done, which is a brain scan, which is we call a CT angiogram, and that has to be done, and that has to show 0 blood flow that is reaching the brain, right? And then only after then can we determine that this person is brain dead.
All right. So this is interesting. And doctor, if you can say what is done in other countries. So once, that's what Dr. Swan has described, how now do you tell the relatives, the loved ones, that there's an opportunity here? Mind you, they're now in a state of grief, but now how do you, is a system in place whereby, now this is Guyana, where you could tell family and loved ones that there's an opportunity for your loved one who can no longer come back to make an impact in someone else's life?
So it's a great question, and it does happen, and it's well validated that it is something that persons actually are receptive to. And in the developed world, the way that we are doing it is mirrored after that. The standard is the same that we have written into our guidelines, and the approach is the same. Dr. Swan and several others within our system have had ongoing and training of several months, and the training is ongoing in this regard, and they have liaised with the persons who do this as a profession in other countries and who are very successful at it. And the lessons and the validation that is there is that intuitively you may think that relatives would not be receptive to this, but the experience is actually the counter. Many are actually very receptive to it, and there's not 100% buy-in, and there will be cultural and religious and other barriers, but no one is coerced in any way to consent to this. And if they say no, if their relatives say no, it's totally understandable. No one is forced. In some countries, they have what we call a opt-out Like, for example, in Barcelona, Spain, the law is so written that everyone is deemed to be a donor unless they opt out, right? So when someone is declared brain dead, for example, potentially they can donate, and the doctors would then inquire of the family if this patient had any express opinion on it. And if they did, and it was no, then they would not. And they also, even though the law says they can do contrary, they also do respect the family's wishes. If the family says that they don't want the donation to occur, then it doesn't. And in our system, it's an opt-in. No one is assumed to be a donor. It is only if you say you wish to be, you would wish to be a donor, or if on the approach to the family says it's okay. But again, there's no coercion, and it's a totally transparent process.
We take a break, and when we come back, we will have more for you on Health Matters.
My name is Leon Seaton, National Swimmer of Guyana, and I received my COVID-19 booster shot. The COVID-19 booster shot has proven to be something very effective, and since I'm a swimmer, it was something that we needed within the world of swimming to participate in games and traveling. So to me, it was very efficient in taking the vaccine. My words of encouragement to you is come out, take the vaccine so that you can go places, do things, and live a better life. Stay safe. Get your vaccines today.
Welcome back to our program, Health Matters here, with presentation by the Ministry of Health, and we're talking about human organ and tissue transplant, the agency that was formed just last year. Dr. Rambaran, let me ask you this. So, we're talking about deceased transplant, but what about people now who, after seeing this program, would say, I would like to put my name as an opt-in from now, regardless for live donor or deceased. Is that available?
Well, we have guidelines in our act that speaks to this, but certainly the Human Organ Tissue Transplant Act is moving towards a donor potential list where persons can opt in, and also specifically a recipient list, because I'm sure persons with chronic renal disease who also will watch this program, they would want to know how can they get on that list. So the agency is actively putting together both lists. With regards to the latter list, that would be the ones who would potentially receive or be recipients of donations. Everyone who has a chronic kidney disease at the end, what we call end-stage renal disease, is a potential recipient. But there will be a process to ensure that they're suitable also. Not everyone who has the disease can suitably receive a donation. So there'll be a process of vetting those persons and arranging an order of priority based on how far the disease is, their age. Just giving examples of factors that are weighed in. And then that list will be dynamically updated over the years to ensure that once organs become available, that these persons would be considered for a donation. With regards to persons opting in on the list, there certainly will be a list available, and it is more so an expression of your wishes. So some persons wear it as a band, a wristband, or they have some thing in their wallet to say that they wish to be a donor. So both will be formalized.
And also to add, these, I know it can be a difficult conversation to have, but a simple discussion at home with your family to let them know what your wishes would be in the event of, like an unexpected circumstance, let's say an accident or so. What will you want? Or I'm saying you, and in terms of the public, what will you want in terms of your wishes? And that in itself can make it so much easier on relatives when they have to make a decision in whether to say yes or no to organ donation.
Dr. Ramon, as we wrap up, is there any countries nearby Guyana that potential persons out there can visit in terms of to get information online? That's the case of that would have got best practice.
So the countries that have this well established, of course, are the developed countries, North America, Europe. But the closest Trinidad, our sister CARICOM country, they actually have a transplant program where they have done deceased donor transplantation. So if we just look across at our neighbors, and if there's more information, there's a wealth of information out there with regards to this matter and how it actually is practiced in other countries. And we do not intend to reinvent the wheel. We intend to do it in a manner that is very guided by the laws, and one which is actually taking all of the experience and what is standard practice from the rest of the world.
Do you foresee in the future, near or far, that there will be changes in terms of laws and regulations?
Well, as I said, the recent enactment of the Human Organ Tissue Transplant Act was done as one of the most modern pieces of legislation in the entire Caribbean. So we have taken on a lot of what we perceive to be changes in the future and things that will impact decision making, and all of those have been written into the law. So Guyana has a very modern tissue and organ transplant act.
Doctors, thanks a lot for being on our program. You've been watching Health Matters, and we've had on our program today Dr. Navijwanath Rambaran, Director of Medical and Professional Services at the Georgetown Public Hospital and a member of the Human Organ and Tissue Transplant Agency, and Dr. Samola Swan, Intensive Care Specialist and recently Transplant Coordinator at the Georgetown Public Hospital, Georgetown. You can call the Ministry of Health for more information on this agency, the Human Organ and Tissue Transplant Agency. My name is Nazim Hussein. Do join us again next time. Until that time, stay safe.